This presentation will discuss the role of dysfunctional autophagy in Crohn's disease. This will be presented by Rahul Dev as a Crohn's disease was first identified in 1932 as an inflammation of the ileocecal valve that progressed proximally or in the oral direction. The image on the left side shows an ileocecal valve that has been damaged by ulceration. The diagram on the right shows the location of the ileocecal valve, with injury to the intestinal wall that is proximal to the valve. Crohn's disease today includes inflammation of the entire intestinal tract. It primarily involves the terminal ileum. This is where 35% of inflammation is found. It progresses both proximally and distally. Skip lesions are characteristic of Crohn's disease. These are discontinuations in the inflamed tissue with unaffected tissue between regions of inflammation. There are over 170 genes associated with the development of inflammatory bowel disease. This presentation will focus on one specific gene, which has implications in autophagy. Crohn's disease is multi-causal and multifactorial. For example, chronic intestinal inflammation may be a result of antibiotic use. Disorders of the immune system are commonly implicated in the development of inflammatory bowel diseases. This presentation will focus partially on the dysfunction of the Paneth cell. This image shows the location of the Paneth cell in the intestinal crypt. The Paneth cell regulates the immune response in the small intestine. The normal behavior of Paneth cells is to produce antimicrobial peptides that help to regulate the composition of resident flora. In this way, Paneth cells regulate the immune response. Dysfunction of Paneth cells are implicated in Crohn's disease. Dysfunction may lead to inappropriate inflammation. Paneth cell hyperplasia and metaplasia are seen in inflammatory bowel disease. Hyperplasia and metaplasia may result from injury. Injury may be a result of chronic inflammation. Therefore, the inflammatory activity of Crohn's disease Paneth cells may create the conditions for the Paneth cell hyperplasia and metaplasia. Paneth cells are found in the small intestine. However, biopsies from a colon that has been subject to chronic inflammation may show Paneth cell metaplasia. Now the discussion will focus on one gene that can cause autophagy dysfunction in Paneth cells, as well as dendrites and macrophages. This chart shows many genes that are associated with inflammatory bowel conditions. The blue circle on the left side represents a disease. The disease represented on this chart is inflammatory bowel disease. The purple circles in the middle of the chart represent the many phenotypes and aspects that contribute to the broader disease. The green circles, for example those on the right side of the chart, represent genes that contribute to the development of the phenotype. There are many genes that contribute to inflammatory bowel conditions, but this discussion will only focus on one. This chart shows the gene of interest. In the middle of the chart is the broader disease, inflammatory bowel disease. The purple circle to the left represents one phenotype that contributes to Crohn's disease. It is referred to as Crohn's disease IBD10. On the left of the chart is the gene that will be the focus of this presentation. Autophagy-related gene 16-like-1, or ATG16L1. An allelic variation of this gene will confer susceptibility to the phenotype Crohn's disease IBD10. ATG16L1 is the gene on chromosome 2. It is located on the long arm, which is denoted by the letter Q in its location. Specifically, this gene is located at position 37.1. This gene location may sound familiar because of a disease called 2q37 deletion, which can cause mental deficit. However, the mutations discussed in this presentation is not related to 2q37 deletion. The gene ATG16L1 has a role in autophagy. In a normal state, autophagy is the process of digestion of pathogens, dead cells, or cell contents. However, this presentation will discuss an allelic variation of this gene, which results in autophagy disorders of Paneth cells, dendrites, and macrophages. Single nucleotide polymorphisms, or SNPs, lead to the creation of an allele called ATG16L1T300A. This allele confers susceptibility to Crohn's disease. Though the inheritance pattern is currently unknown, familial clusters of Crohn's disease does exist. ATG16L1T300A allelic variation results in both loss of function and gain of function mutations. Cells that express this allele lose the function of effective autophagy, and they also lose the function of effective antimicrobial capabilities. The cells gain a function of increased cytokine secretion. The first dysfunction to be discussed is the loss of effective autophagy. Paneth cells with the allelic variation exhibit a disorder of the endoplasmic reticulum and Golgi apparatus. This results in the ineffective packaging and release of lysozyme. Normally, autophagy maintains the intestinal barrier by removing dead cells and removing the protein Claudin-2. When Claudin-2 is allowed to act, it degrades tight junctions between epithelial cells in the intestinal wall. With allelic Paneth cells, autophagy is decreased because of decreased lysozyme, and the intestinal barrier is compromised. There is a proliferation of dead cells and an excess of Claudin-2. Therefore, the tight junctions will be broken and the intestinal wall will become more permeable. The second loss of function mutation to be discussed is the decrease of antimicrobial activity. Allelic Paneth cells have a decreased release of antimicrobial peptides. This will result in a lower defense against bacterial infection. The intestinal wall has already become more permeable. Therefore, there will be increased opportunity for bacterial infiltration into the intestinal wall. This will result in inflammation, injury to the intestinal wall, and thickening of the intestinal wall. Furthermore, dendrites that express this allelic variation have a decreased capability to present bacterial antigens to T cells. Therefore, there will be less opportunity to resolve the infection. Lastly, a gain of function mutation will be discussed. Macrophages, which express this allelic variation, have an increased secretion of interleukin-1 beta. Interleukin-1 beta activates the inflammatory response. Increased cytokines activity will also create a population distribution in which there are an abnormally high proportion of pro-inflammatory macrophages and an abnormally low proportion of anti-inflammatory macrophages. This will result in a state where there is a substantially decreased opportunity to put an end to the inflammatory response. Now the discussion will move to pathological changes of the Crohn disease. Going down the left side, there is hyperplasia in the lymph node. This is an abnormally high rate of replication of lymphocytes. Linear ulceration. Ulcers form due to chronic inflammation. This presentation has already shown how just one out of the hundreds of inflammatory bowel genes can cause inflammation that is inappropriately activated, inappropriately exacerbated, and has little opportunity for resolution. When an ulcer progresses through the entire intestinal wall, the mucosa, submucosa, and muscularis, this is called perforation. Fluid can collect into an abscess in the extra-intestinal space, or the ulcer may progress into another organ, forming a fistula. Here a fistula has been formed between two sections of the small intestine. On the bottom of the left side is a granulomatosis lymphadenitis. This is a collection of immune cells with inflammation and swelling of the lymph node. Going down the right side, there is a skip lesion at the top. This is a region of non-inflamed tissue between regions of inflammation. The lumen or open space inside the intestine has been narrowed because the wall has thickened. This is due to chronic inflammation, which is presented at the bottom of the figure. Figure A on the left side shows a real stricture of the terminal ileum. There has been injury to the ileocecal valve, which is on the left side of the picture. Figure B on the right shows linear ulceration and edema. The edemas form what is referred to as a cobblestone texture. These longitudinal ulcers can perforate to form abscesses or fistulas. Patients typically present to the healthcare provider with abdominal pain, typically of the right lower quadrant, weight loss, and diarrhea. Diarrhea is less likely to be bloody compared to ulcerative colitis. There is fecal urgency, and diarrhea can cause dehydration and electrolyte imbalance. Patients may present with malaise, which is a general discomfort and tiredness. The small intestine absorbs 90% of nutrients from the diet. Therefore, if there is significant injury to the small intestine, this can result in malnutrition. The ileum, which is the primary site of inflammation in Crohn disease, absorbs water, bile salts, and vitamin B12. Decreased absorption of vitamin B12 can lead to anemia. Decreased absorption of bile salts leaves lipids in the feces. Therefore, there will be steatorrhea, which is oily or fatty feces. Most importantly, malnutrition in children can result in growth deficiency. Diagnosis of Crohn disease. Endoscopy of the sigmoid colon and terminal ileum are commonly performed to investigate inflammatory bowel disease. Sharply demarcated skip lesions are characteristic of Crohn disease. Contrast imaging is used to study the small intestine and investigate fistula formation. Biopsies of the intestinal wall may be taken and analyzed for an increased leukocyte count. The levels and types of leukocytes present can help to differentiate between acute and chronic inflammation. Severe complications involve perforations of ulcers. This is when an ulcer extends through all layers of the intestinal wall. Abscess formed by the perforations can rupture into the peritoneal cavity and cause peritonitis. Perforation can also lead to fistula formation between sections of the intestines, between the intestine and bladder, which is an enterourinary fistula. The patient may present with fecal uria, which is feces in the urine. A fistula may be enterocutaneous. This can result in peristoma, which is an opening from the intestine to the skin. A stoma may also be a surgical method of treatment to bypass the intestines when there is significant damage. These charts show systemic manifestations of Crohn disease. A common manifestation of inflammatory bowel disease is uveitis, inflammation of the uveal tract of the eye. Other manifestations are gallstones and cholangitis. Notice that psoriasis and rheumatoid arthritis are outlined in yellow. Not only can these conditions be caused by an abnormal immune response similar to Crohn disease, but they may in fact share some genetic basis. This chart from the beginning of the presentation shows a genetic linkage between inflammatory bowel disease and psoriasis. One gene which links them may contribute to the development of both conditions. The same pattern is shown here with a specific form of systemic juvenile rheumatoid arthritis and susceptibility to lupus. Treatment of Crohn disease may include corticosteroids. These drugs work by altering cell glucose metabolism to reduce the immune and inflammatory response. A low-residue diet may be prescribed. Dietary residue is non-digestible matter. The goal of the diet is to reduce bulk in order to reduce the size and frequency of defecation. Psychological stress has been shown to exacerbate inflammation through the stimulation of the sympathetic nervous system. Therefore, psychological therapy should be considered. Severe cases of malnutrition may warrant IV nutrition. This allows the intestines to rest because they do not need to work to transport and digest food. Additionally, IV nutrition may be helpful as a supplement for those with malabsorption. Finally, Surgery is typically required to treat fistulas and other forms of extremely excessive damage. Resection removes a portion of the intestine and reconnects the free ends. A stoma bypasses injured intestinal tract and has an opening to the outside of the body wall. This may be temporary or permanent. An abscess will require drainage. This diagram illustrates the process of resection. A fistula has formed between the ileum and sigmoid colon. The fistula has been severed, the sigmoid has been sutured, the cecum and terminal ileum have been removed, and the remaining ileum has been attached to the ascending colon. As with all diseases, there is always more to learn. Crohn's disease commonly presents in 20 to 4-year-olds. However, special attention should be paid to children because of severe implications of growth deficit. Crohn's disease is more common in women than men. Thank you for watching. This discussion of dysfunctional autophagy in Crohn's disease was presented by Raoul Dev